Hi, my name is Andrea Taylor, and I'm the president and founder of A Twist of Fate for Arterial Tortuosity Syndrome. We are the patient group nonprofit, and we have come together as a collective because we realized that with arterial tortuosity syndrome as a condition by itself, we are just such a small patient population that we needed more robust connections. And so what we did is we wrote this grant to start the Connect project. Armelle and I did. And what we wanted to do was to look at all the different connective tissue disorders that are similar to ATS with aortopathies and kind of compare them to see where they were science-wise. We already work with a lot of the same clinicians and kind of see what the patients had to say about their conditions and the similarities. And what we found has been really interesting. So I'm going to introduce you to Dr. Armelle Pindon. She is our partner on this project, and she is going to be doing this presentation. She has her PhD in neuroscience, has experience in both academia and industry. She was at the Institute of Myology in Paris, France, and the Department of Neuroanatomy at Guy's Hospital in London in the UK. Moving into the pharmaceutical industry, she was the project leader for neuropharmacology and later in metabolic disorders. Armelle's career has focused understanding on mechanisms of neurodegeneration, neural lesions, and translating this knowledge into the discovery of treatments. She is now the Chief Scientific Officer at Cure VCP. This presentation is not meant to be in replacement of medical advice, and there'll be a disclaimer at the end of the video. If you have any questions or concerns, our emails will be located at the end of the video as well. Thank you very much, and we will start our presentation.
Hello, welcome to this webinar. We are reporting on the patient perspective on connective tissue disorders and finding commonality. I am Armelle Pindon, and this is my disclosure. Connect stands for the Cardio-Ocular Network of Connective Tissue Disorders. The Connect project is a rare patient perspective on rare diseases based on a multi-stakeholder and multidisciplinary partnership. Our goals were first to build a network of patients, clinicians, and scientists interacting as equals. Then the next goal was to produce an analysis leading to a research solution in which all stakeholders will have a role in helping to implement and improve a platform to identify commonality across connective tissue disorders and build a strategy for removing roadblocks in building effective and patient-relevant clinical options, patient-centered outcome research, and improving quality of care. The project has three different parts. In this webinar, we report the first part, the patient perspective. We ask the patients about their experience with their symptoms, medications efficacy, challenges, and fears. Then we brainstorm with the patients on their view on gaps and solutions in developing clinical options and their view and gaps and solutions in quality of care. The methods we used were qualitative and quantitative. We used a survey containing over 40 questions in 3 sections and IRB approved and unidentified data. The data were collected on REDCap and statistical analysis were performed on 143 patients. Then we had 3 virtual interactive webinars with patient panels representative of 6 different connective tissue disorders that we combined with an open discussion with the audience. This is the analysis of the demographic representation in the survey. The responders were almost equally distributed between patients themselves and caregivers, parents of child and grandparents. The patients were located mainly in the USA, but we had also patients from Europe, Australia, and Canada. The age of patients was in accordance with what we reported in the quality of responders. They were half pediatrics and adults. The disease representation was equilibrated between Marfan, LDS, ATS, and Mayer syndromes, with a lesser proportion of cutis laxa and VDS. And what was mentioned here as others is Malan syndrome and FG1 syndrome. The age of diagnosis reflects the different type of connective tissue disorders, the pediatric and the late onsets, or the adult onsets. The late diagnosis reflects not only late onsets, but the diagnosis odyssey and difficulty encountered by some patients in connective tissue disorders. The mode of diagnosis is based on genetic testing for more than 70% of the patients, with only around 10% of the patients being diagnosed only based on clinical observation. The use of genetic testing might reduce the length of diagnostic odyssey in the future if it is more often used by the clinicians. When we look at the family history of the disease, we see more de novo than inherited origin of the disease. This can be due to recent characterization and identification of these symptoms, also a history of misdiagnosis, and/or it reflects the recessivity of some of the connective tissue disorders. It is a majority that's reporting in the line of first parents. We evaluated the daily impact and the burden of the disease. We observed that the quality of life is altered beyond the medical aspect. 70% of the patients and caregivers are limited in their activities. The time span when the patients were limited in their activities was for more than 70% over years, showing the long-term burden of the disease rather than an episodic effect. The challenges encountered by most of the patients are listed in the table. And the main was to take longer time than expected to finish program, then reduce job responsibility for approximately the same percentage, around 30%. Then the caregiver also is impacted. So you can see that they reduce activity, school or job responsibilities for almost a third of them. And if you go to the fourth line, you will see that 40% of caregivers even quit their job, school, or they lose their job or change the job due to the disease. So it's not only impacting the patients, it's impacting also the caregivers. So for the pediatric, you have reduced school activities. The effect also on the whole family, marital difficulties, was shown on 12% of the answers, which is quite low. It should be, usually it's higher with rare disease and especially pediatric disease. We could see also that people were not able to go to school or were even homeschooling for almost 12% of them, and repeat a year or more of school for 9%. The family even move or change location due to the disease for 7%, and even needed to quit school for also 7%. But the impact that we have to really take into consideration is the social isolation that was reported by almost 14% of the patient as being one of the 5 most impactful consequences of their disease. We asked for the manifestations that were the most important for the patients and identified the common ones. We had 2 surprises, including that were 2 manifestations that were included neither in diagnosis criteria nor in the standard of care. That was the gastrointestinal and fatigue that were in the top 3 manifestations. Neuropathy was also a surprise, was reported by 9%, even more than 9% of the patient, which is more than 4 times the incidence in the general population. The gastrointestinal manifestation was reported as the main one for 46% of the patients. That's including bloating, pain, dysmotility, constipation, and/or diarrhea. In a less extent, inflammatory bowel and esophageal disease were reported for almost 6% of the patients, and feeding difficulties were 11%, more than 11%, and difficulty swallowing for 12.6%. The other reported in the top 3 was the fatigue. And fatigue can have different origins, can be metabolic with a decrease of ATP synthesis, the NADH system deficiency, oxygen deficiency, muscle fatigue with oxidative stress response elements. The patients report cardiovascular manifestation, muscle weakness, and metabolic issues. We taken individually or in combination are a source of fatigue. Our original focus was on cardiovascular and ocular manifestations, so we asked for more details in these manifestations. We could see that high blood pressure and lightheadedness were the most reported, followed by aneurysm and palpitation. For the ocular manifestation, myopia and astigmatism are high, but they are also high in the general population. But the keratoconus and keratoglobus are really an issue linked to connective tissue disorders with a high threat of blindness. To assess the impact of quality of life, we looked at the severity of the manifestation. The number of hospitalization due to connective tissue disorders in 2022, so the year before, where 60% of the patients were at least once recovered, more than 10% were hospitalized more than 5 times in a year. The time spent missing work for adults was over 3 weeks for a majority of the patients, showing again a high impact on their adult lives. Asking for the type of medication and the effectiveness of the treatment, we could assess the medical needs. The first one was pain and was very common. The need for medication was really going from over-the-counter to opioids, anxiolytic and anxiolytic medication, so really a vast array of medications. The effectiveness, of course, were higher with the opioids derivative medications. The next one was anxiety. The number of anxiety medication was really high, and those medication was different from every patient. The answer, except for the Prozac, were reporting 2 times, but all the others it was just one person reporting, and the efficacy are for most of them above 6. And for a few of them, not really efficient, and for Xanax, not efficient at all. So the class of medication were SNRI, SSRI, SDRI, classic, amitriptyline, hydrochloride, presynaptic ACT or NET, and GABA agonist. So as I mentioned, the effectiveness is a report of N of 1 because almost each patient had a different medication. The muscle relaxants were also used by a part of the patients. There are 3 classes of molecules: the GABA agonist, alpha-adrenic agonist, benzothiazole, and cyclobenzaprine. Zanaflex had only an N of 1, was not really effective. Baclofen were the most used, and cyclobenzaprine was also used, and the efficiency was really, for both of them, were not really high, mainly, and really going from 2 to 8, so not really standard. The hormonal treatments were reported only by 9 patients. Each type of molecule was only N of 1, except for levothyroxine, which was 2 patients. The efficacy was quite high, for an 8 and a 10. And for the sexual hormone, we were reported as contraceptive, progesterone, estrogen, targeting gonadotropin or lutein hormone, or gonadotropin releasing hormone to decrease testosterone levels. Some of them were really totally inefficient, and the estrogel was really efficient. The blood thinners were reported by 12 patients. Some were, again, only medication for 1 patient, reported by 1 patient. Aspirin was reporting by 2 patients. And the most common one was warfarin, reported by 5 patients, and was very efficient. The efficiency was between 9 and 10. The hypertension medication were reported by 39 patients, so way more common than the other I just mentioned. There were mainly 2 types of medication. The angiotensin II receptor antagonist were reported by 19 patients and were highly efficient. And the beta blockers were reported also by 19 patients and were also quite efficient, more for the metropole than the other one. The bowel management medications were reported by 18 patients. Also, all different type of medications. That's also 80 patients. Doesn't seem a lot, but the patients, in fact, reporting gastrointestinal issue were not taking medication for it, except those Miralax mainly. At the interactive panels, preliminary results of the survey were debated in addition to the testimony of the panelists and the participation of the audience. We identified the priorities on new clinical research topics largely, and we saw that it largely varied depending on the patient population. So the pediatric were more focused on life-threatening issues, and the adults wanted to focus on pain management. So in fact, it's the reaction of the parents wanted to protect their child. Of course, wants to focus on life-threatening issues, but the adults are really concerned by their daily life, and in their daily life, pain management was the main issue. So the common fear between all of them was, and the worries were identified as the life-threatening cardiac and arteriopathy issues. And what is surprising is that the priorities for new clinical research do not match for the adults with the common fear. So the adults have fear about life-threatening issues, but their main concern is pain management. So the proposals that were offered at the end of the brainstorming and panels were to create a connective tissue disorder specific pain research center to characterize the type of pain using MRI, quality sensory testing, clinical assessments of pain, and condition pain modulation. The other proposal was to include gastrointestinal discipline in the standard of care for connective tissue disorders. And the last proposal was to work on the incapacity of connective tissue patients to use CPAP due to a common interface feature preventing the mask from really fitting properly to their face, so they cannot use it during sleep. So the cornerstone that was really identified during those panels and from the survey is really the collaboration between patients and clinicians. So the research in identifying or comparing clinical options is only possible if there is a clear definition, knowledge, and tools to perform it. So we discussed and identified the challenges through the survey and the panel, and what we identified was the lack of knowledge about the rare diseases or even ignorance of their existence when the patients go to clinicians or the emergency room in hospitals. The second challenge was only very few centers of excellence exist and know about each condition. So this is a focus where all the connective tissue disorders should really improve what they do, many through their organizations, patient organization, but really accelerate and improve the number of center of excellence for connective tissue disorders. The third one is the patient or caregiver cannot use technical terms to describe the symptoms, particularly when they arrive at the ER in condition of vulnerability. They cannot communicate properly with the clinicians, and then the clinician cannot use the proper clinical answer because they don't have the proper information. So those are really the three challenges that would be put in priority to work on. The research in engagements leads to the tools for clinical research. So what we proposed as comparative research are three methods that we could compare. First, the patient brings the expertise and knowledge to the physicians, either in a printed booklet or on a QR code on a business card, or with a checklist and instruction on standard of care. The second method could be the patient introduces the physician and clinician in a center of excellence, or to a clinician expert in the disease. That's not for the emergency, of course, in emergency room in hospitals. That's more when you go see your physicians. The third one is creation of a connective tissue disorder app on the phone, warning the physicians that the patient needs special attention and giving access to a standard of care for emergency also, and including the risks specific to the patients. What was noticed during these debates is that we should pay particular attention to the training of the young patients, the teenagers or younger, to properly communicate their symptoms and risk also. And we should adapt the methods that we use for adults to the teenagers and younger patients, so that they can communicate properly also themselves without their parents. So in conclusions, the symptoms most relevant to the patients are not included in the standard of care or part of the description of the connective tissue disorders, and then have unmet medical needs. The lack of effectiveness in connective tissue disorder patients' care outside of connective tissue disorder clinic centers of expertise is a liability for patients. And effective solutions are proposed with this project and should be explored with collective participation across patient disorders. So we want to thank particularly the PCORI. The Connect project was funded by Eugene Washington PCORI Engagement Award. That's thanks to them that we could do all this analysis. And they wanted to, PCORI is not responsible for all the results and this webinar. So I thank you for your attentions, and we are open for question and answer.
Thank you, Dr. Pindon, for the amazing webinar and all that we're learning about patient experiences with rare connective tissue disorders with aortopathies. This is a recording and it will be placed on the YouTube channel. You can also find it on www.atwistofate-ats.org on the Connect project page. If you do watch this video on YouTube, please be sure to leave your comments and your questions on there. If you have any comments or questions that you would like to send privately, you can email them to Andrea, ANDREA, at atwistofate.org. Thank you, and I hope that you enjoyed the presentation. Please keep in touch and keep checking back to see what we're doing next with our Connect project. We're going to have different events throughout this next following year. Thank you.
Thank you all. Bye.